Okay, we are back. A little bit of a delay since my last podcast. I've been busy. Of course, you know I'm always busy, but I'm always doing something different. I started to go back into surgical pathology, so I kind of go to the hospital and work now in addition to autopsy work. And so that takes up a lot of time because I'm in the hospital all day and I don't always have time to record because it's pretty busy. But anyway, I'm back, and today we are going to talk a little bit about seizures, just some housekeeping stuff up front. Usually I respond to any emails or DMs or comments that I got regarding anything in the last podcasts that I've misspoke about or something, and I didn't get any for the last one or the one before that. So there's really not much to address on that front. Also, before we get too far, I want to remind you of my socials. YouTube, Knife After Death, same as name as this. I'm starting to do a few more videos over there now. And Instagram and TikTok are The Dead Letter. And of course, my Substack is Dr. Darren Wolfe. That's where I'm doing like the bulk of my teaching. Every Friday I put up a Forensic Friday case for everyone to have a guess at, and then Saturday I sort of release the solution and do a little bit of teaching on that. And I show a little bit more surgical path over there. So yeah, that's kind of the update. So let's get on with today's episode, which is about seizures. And I want to preface this by saying that this is not a lecture on neurology, okay? If you're a neurologist listening to this, or you're someone who has seizures or is in the medical field dealing with a lot of patients with seizures, this is not something that's going to go over all of known knowledge on seizures. That's one of the problems that we have with medical content creators, is that if you don't mention everything, then you get a lot of comments and questions like, hey, you forgot this, you forgot that. No, today we're going to be very focused because remember, I'm a forensic pathologist. So we are going to talk specifically about the forensic pathology of what we find at autopsy with seizures, okay? And specifically what we find with someone who maybe either we don't know they have a seizure disorder, or they do have a seizure disorder and they die in an unwitnessed fashion, okay? Because if it is a witnessed seizure and they die, that is called status epilepticus, and that is very easy to sign out. I mean, it's debatable whether you would even need an autopsy in that situation. The cause of death, status epilepticus, or sometimes people will just say acute seizure. I tend to just write acute seizure. Manner of death, natural. Get some toxicology to see if there's any other medications in their system. Also to see if they have their seizure medications within therapeutic range. So that's a very easy case. That's really not one that probably gets autopsied very often. However, I'm talking about a person who has a known seizure disorder for whatever reason and is found dead at home. They're found dead in bed, commonly, actually. Or, the other situation where we don't even know the person has a seizure disorder. Maybe they haven't gone to the doctor, they don't have a lot of family and friends, and they don't, it's something that could even be a new seizure that comes out of nowhere. Sometimes people can manifest seizures in adulthood out of nowhere. So let's first talk about what that means. So the most common situation, and I see it just a handful of times a year, let's say 5 or less times per year, which is 2% of my cases or something like that, is what we call SUDEP, SUDEP, or sudden unexpected death in epilepsy, or of an epileptic. In other words, an epileptic person, a person with a known seizure disorder who is found dead. Because if you have a seizure disorder, that doesn't mean you're going to die of a seizure. You could very well die of a drug overdose, or die of electrocution, or die of drowning, or die in a car accident, and not necessarily due to the seizure. But we're talking about mostly a situation where a person is found at home, deceased, with the history of seizure. So what do we find at autopsy? Well, so far in my career, these patients tend to be younger. They can be very young children who have had epilepsy or seizure disorders since birth, teenagers especially, and then on into the 20s, people who've had chronic seizures for 2 or 3 decades of their life. Why do we see it commonly in teenagers? Well, number one, a fatal seizure can occur in the setting of a person who has not really had any kind of like severe seizure. So you can have seizures that are manageable for years and years and years, and then have one that is fatal. That is an unfortunate reality of the seizure disorder. But the reason why teenagers sometimes are a little bit more susceptible is that, in my experience, cases that I've seen, once people get to their teenage years, they become a little more independent about taking their medications. And sometimes they think to themselves, hey, I haven't had a seizure for 2 years. I don't know that I even need this medication. And they either stop taking it or they take it infrequently, which results in, unfortunately, the seizure coming back and causing death. So what we'll do in that case is, of course, we do the full autopsy. We get the toxicology, and we find their medical history, and we find out what type of seizure medications they're on, and we look and we see, are these medications present? And if they are present, are they present at levels that are considered therapeutic? So other times we have younger kids who have such severe seizures, such severe epilepsy, that no amount of medication is unfortunately going to help prevent death. You just take the medication, you keep it in therapeutic range, and you hope that they don't develop that severe seizure. So let's first talk about that. What do we see at autopsy? Now, first of all, this is one of those diagnoses that is a diagnosis of exclusion. Okay, those are very frustrating cases personally, because there are no pathognomonic findings. Now, remember, we recently did a podcast on drowning, and in drowning, unfortunately, there are no pathognomonic findings. Pathognomonic, if you haven't listened to my podcast before, that is a word meaning specific for a particular disease. So we don't do an autopsy on a person and say, aha, clearly this is a seizure, we can go home now, and the case is over. Much like you would if you saw a heart attack or an aortic dissection or a ruptured Barry aneurysm in the brain, you know the cause of death standing there at the table. Tox is minimally helpful in cases like that. But with the seizure, you have to go with a lot of clinical background and toxicology. And sometimes you even have to do histology and look at the brain and see if there's something causing the seizure. Now, we can talk about these clinical elements, but I know that you're curious, what do you find in the seizure? And by the way, if you hear the creaking in the background, it's because I'm sitting on a wooden chair and it's creaking as I move a little bit left to right as I'm speaking into an imaginary audience. Anyway, so there are a few things that you can look for that are helpful. Okay, number one, and by the way, when I say number 1, 2, and 3, these are not in order of importance. They're in order of how they're coming out of my brain. Pulmonary edema, okay? So sometimes you get you get the cardiorespiratory arrest, okay? The heart and the lungs, you stop breathing, and you can get kind of a profound pulmonary edema, fluid in the lungs. And what happens is when you find the person at the scene, they very often will have what's called a foam cone, which means white foam at the mouth and the nose. Now, we can see the foam cone with other things. We can see it with drowning, and we can see it with drug overdoses, in particular opioid overdoses. And that's the same, and it's for the same reason. You get a cardiorespiratory arrest that's fairly sudden. And you might get the respiratory arrest before the cardiac arrest, and that can cause the fluid backup, which is a little bit, it's hard to study because these are conditions that you can't control for. You can't do experiments and show why this is the way it is. But pulmonary edema is a good one. And so that's manifested, like I said, with foam inside the airways, and also the lungs themselves are heavy. So the weight of an adult lung is usually about 300 to 400 grams each. For a child, it can be smaller, of course. If we're talking about a toddler or a 10-year-old, we're in the 100 gram to 200 gram range, somewhere in there. And so with severe pulmonary edema, usually the lungs are going to be combined. They're going to be like 800, 1,000, 1,200, 1,600 grams they can be. Okay, so that's number one. Number two is going to be cerebral edema. So sometimes you will see the swelling of the brain, and this is manifested in when you take the calvarium off the top of the skull and you remove the dura mater. The surface of the brain is more of a smooth appearance. It's more like undulating than it is where you can see the deep gyri and the sulci on the surface of the brain, the so-called wrinkles that are really prominent in a normal brain. In a swollen brain, they kind of squeeze together. And that's because as the brain swells, it's swelling against a very hard piece of bone, and then it flattens it out. Okay, so other things you can find include the tongue bite. So, okay, this is something that's a little bit controversial because people think, if you have a seizure, your jaw tenses up and you bite your tongue, and this is going to be seen in every case. But the truth is, you hardly ever see it. It is something that's very, very helpful if you find it, but if you don't find it, it doesn't rule it out. I would say in all the seizure disorder deaths I've had, I would say I've seen a tongue bite where basically you see like a laceration of the tongue with a little bit of contusion around it, a little bit of ecchymosis. I would say I've probably seen it in 10% of all of my cases. Other times you can see, you'll see cyanosis or blue color of the face, again related to the respiratory arrest. Sometimes you will see posturing of the arms and the legs. Sometimes they'll call it decerebrate posturing, where you have like the wrists flexed and the arms extended. It's even been reported that these can manifest in fractures if they're severe enough. If the muscle is flexing tightly enough, it will cause a fracture of the bones. Now, first of all, I guess I probably jumped to the forensic stuff before really talking about what a seizure is. People who are, even tangentially related to healthcare understand seizure, but I know a lot of people listening to my podcast are not healthcare. They're not educated in healthcare, and yet we know basically what that means, right? It's an electrical discharge from the brain that kind of overwhelms the bodily systems. And the seizures, there are many types, and the seizures that are dangerous are called tonic-clonic. So in other words, those are the jerking, flexing type seizures that you think about when you think of a seizure. But there are other types of seizures that can cause hallucinations, that can cause you to just kind of glaze over and stare into space. Those are called absence seizures. And so, like I said, this is not a neurology lecture. We're talking about tonic-clonic. Some people used to refer to this as grand mal, and this is something that I have to address because no matter where you are, I'm in the Midwest, southern Indiana is where I grew up. People used to say grandma seizures, as if it's a seizure that a grandma has. And you might be laughing, but that is absolutely how people pronounce it, and they think it is somehow related to being an elderly female. So-and-so had a grandma seizure and died. No. It's grand mal, meaning very bad. A big, bad seizure is what grand mal seizure is. But, again, that's kind of synonymous with status epilepticus. Okay, so now that we understand this, where does it come from? Why does it happen? Well, sometimes we don't know. Sometimes seizures can arise, epilepsy can arise in infancy or in early childhood, mid-childhood, and there's no definitive reason for it. You can do MRIs and EEGs and all of this blood testing, and you just don't find a reason for it. Obviously, there are other scenarios where you have an actual lesion in the brain that causes it. This is the minority of cases, actually. You don't see much with, or you don't see many cases where the person has a seizure and you look into their brain and you actually find something on a scan. I personally have never, in all of my cases, which is probably over 3,000 at this point, I have never had a seizure death where I opened the skull and actually found a brain tumor or something that caused it. Now, that being said, brain tumors can cause seizures. Other things can cause seizures like vascular malformations, okay? So that's where you have like a collection of blood vessels that are abnormal that shouldn't be there, that for whatever reason they cause seizures. One kind of rule of thumb is that the older a person is when they have a seizure, the more likely it is to be an identifiable lesion in the brain. So 5-year-old has a seizure, it's most likely kind of an idiopathic epilepsy. But if a 71-year-old has a seizure, you're much more likely going to find a problem physically in the brain when you do a CT or MRI. Now, I will say more likely doesn't mean always. Let me give you an example. When I was in medical school, I had a professor of physiology, and he was, I don't know his exact age at the time, but I know he was probably at least 50, perhaps even close to 60, but certainly not a spring chicken and not super elderly. And he was doing fine, healthy guy, looked good, no problems, but then had a seizure at some point during my second year of medical school. Apparently he was driving, pulled over, had a seizure. Obviously everyone was very worried that they were gonna find something there. Of course, being medical students, we're all thinking, yeah, this is probably going to be a glioblastoma multiforme. He's the right age for it. Seizure with presenting cause. And as it turned out, it was idiopathic. There was no reason for this man to have a seizure, but he had a seizure. And so life is weird sometimes. Pathology is weird. The body is weird. And things like this can happen. However, on the flip side of that, I have known people kind of in my personal life, friends of friends and distant connections where the presenting symptom was a seizure that ended up being a brain tumor. I've also seen it for venous malformations like I mentioned earlier. So one of these days when I'm doing an autopsy, I know I'm going to finally find a lesion in the brain that caused the seizure. But so far, I'm 0 for 3,000. Well, I guess it's lower than that because if I only count my seizure cases, it's probably like 0 for 20. However, it is something to keep in mind. It has to be worked up. You have to do scans to make sure that there's not something in there. Now, sometimes seizures can be post-traumatic. Now, here's where we're getting into some interesting stuff about manner of death, okay? Because a person that has seizures that dies, they might die, in an accidental way. They might die while they're driving. They may drown in a bathtub or something like that. But if you have an identifiable cause for the seizure, it can actually change the manner of death. So let's first imagine a situation where you have a person with epilepsy, known epilepsy. It's idiopathic, meaning there's no defined cause. That person is found, let's say, in a bathtub, submerged. They are dead. We do the autopsy and we find that their prescribed anti-epileptic drugs are absent. They just stopped taking their medications. The findings are at least moderately suggestive of a seizure, and the most likely cause in this case would be a person who had a seizure, slipped underneath the water, and drowned. So that's something that you actually see reasonably commonly. In that case, it ends up being a seizure, contributory drowning. But if the initial chain of events is considered to be from the epilepsy, then the manner of death is actually natural. Now, most medical examiners will still call that a drowning and they'll call it accidental. There's a little bit of controversy. However, let me tell you about another scenario. Now, there is a sort of friend of a friend I know that has a family member that was injured. They received a head injury playing a sport. Okay, I'm going to be a little bit generic because I don't like to talk so specifically about cases, and then people listen to it and they sort of get irritated that, maybe I'm talking about them or something. But the person was playing a sport and got cracked hard on the head. After playing that, after that happened, there was, hospitalization. There was maybe even some brain surgery that kind of repaired the fracture of the skull. And afterwards, they had a seizure disorder. And that seizure disorder was severe, and it was barely treatable by medication. There were surgeries that occurred. The person, obviously they're still doing okay, but you have to think about what was the initial thing that caused the seizures. So if that person were to pass, even in their home, and it ended up looking like a regular old seizure, we have to ask what caused the seizure. Well, in this case, the manner of death will actually be an accident, because the initial thing that caused it was an accidental impact with the head, with some kind of sports equipment, which caused the fracture, which then caused the epilepsy. So it would be something like status epilepticus or SUDEP, and then manner of death accident, and then you would give a note and you would talk about how the injury resulted in the epilepsy, which then resulted in the death. Now that's kind of interesting. A lot of people don't realize that about forensics, but you have to go back to the initial thing that caused the injury. Now, or that caused the epilepsy. Now let's imagine a second scenario where, let's say, two men are fighting in a bar. They go outside. One man pulls out a lead pipe or a chain, whacks the other guy in the side of the head, fractures his temporal bone, injures his temporal lobe of his brain, survives, but then has a seizure disorder. If that person with a seizure disorder at any point forward in their life dies of that seizure disorder, then that case is a homicide. And that person who inflicted the injury initially can actually be tried. Now that's going to be different, depending on your jurisdiction, depending on how aggressive the family wants to be or how aggressive a attorney wants to be on this case. But if an injury inflicted by another person results in a seizure disorder, which then results in death, then that would be a homicide. So it's just more of an exercise of how we deal with manner of death in that case. Now, I want to say one more thing on this topic, and that is about SUDEP, the real SUDEP cases that we see. Remember, sudden unexplained death in epilepsy. The most common thing I see is a person in or around their bed who has passed away. And they are found in the morning by somebody else that lives in their house, or by somebody who, if they're living on their own, comes to visit them, either a friend or a family member. They find them dead, and then they are brought in for autopsy, because we kind of have to prove what happened at that point. Again, a person who dies at home alone unwitnessed, it could be a murder, it could be an accident. They might have reached behind their washer dryer and got electrocuted. It could even be a murder. So we have to do autopsies in those cases. And what we do is, again, we find usually a little bit of brain edema, pulmonary edema, foam cone at the mouth. The scene examination is sometimes helpful. The scene examination can show a kind of a disordered bed, like maybe they were having an active seizure in bed. Maybe there's a lamp knocked over on the nightstand. Things like that. We searched the scene for their anti-epileptic medications, how much is left, were they taking the proper amount from when they got prescribed, that kind of thing. And then if you're lucky on the autopsy, like I said, you might find a tongue bite, or you might find a broken bone or something like that can help you. And then, you can look under the microscope at the brain and see if you can find something microscopic that indicates why this epilepsy was there. Now, you can find what's called hippocampal sclerosis. So in other words, like scarring in the hippocampus of the brain. But this is somewhat, it's not really that helpful, because people who have recurrent seizures can have this finding, and they think it's due to intermittent hypoxia, or low oxygen, that produces the injury in the hippocampus of the brain. And if you want to see where the hippocampus is, just go to Google and type it in. It's a very important structure for things like memory. But yeah, so this is what we find with cases like that. So, as long as we don't find something like blunt force trauma, a gunshot wound, stab wound, ligature mark around the neck, we can rule out homicide at that point. We do the blood toxicology, and we rule out medications that could be used for overdose, either medications or illicit substances. Of course, the scene's going to help us rule out things like accident, like I always bring up electrocution or drowning or something like that. And then what happens is the most important one for me is to look at that toxicology and find out what anti-epileptic medication the person was on and see if it was therapeutic level or not. Now, here's the asterisk on that. You can find it at therapeutic level and a person can still have died from a seizure. That is the unfortunate reality of seizure disorders, is sometimes they can have that effect. You can have no seizures for 5 years and then suddenly have a seizure. So that's something to consider. It can't rule it out. So if you find therapeutic level medication, that doesn't mean, they had to die of something else. It still gets called sudden unexpected death in epilepsy, or SUDEP. Now, the biggest question of all is, why does this happen? And this is a source of debate among pathologists and neurologists and all sorts of physicians. Why does a person who is otherwise healthy, who does have an epileptic disorder, suddenly die? Well, the only thing that we know is that a few theories have been put forward. One is that this huge electrical discharge from the brain also affects the vagus nerve, which is cranial nerve 10. It's a nerve that goes down through your neck and actually helps with your breathing and heart rate regulation. So imagine like a fuse in your house gets shorted out and the power goes out, and then you have to go out to the fuse box and click it back, and then everything comes back on. Well, they think that could it be that this big electrical surge shuts down the vagus nerve, which unfortunately we can't go back and flip the switch. It just stops the heart. I think that is actually a very reasonable explanation in this case. So, there's really not a lot of good. There's just been a lot of speculation about how the disorder can, produce a sudden death like that. And actually, even though I mentioned that the scene can look disordered with a grand mal seizure, not a grand mal seizure, sometimes the person is perfectly still and hasn't moved at all. And that's why they think this could be related to arrhythmia. So like I said, the vagus nerve being affected and then heart arrhythmia being, generated, which stops the heart. So that is the best theory right now. I think it's a reasonable theory, and it's a very hard thing to study, because to really know exactly what happens in cases like this, you would have to have advanced monitoring on the patient, and at the same time they go into a cardiac arrest due to seizure activity. So to really, I guess, to prove this, you would have to have somebody probably hooked up with an EEG machine on their head and an EKG and something measuring, pulse ox, blood pressure, and the whole deal, would probably be helpful to know the exact mechanism of how this happens. So right now it's a mystery, and hopefully one day we'll figure it out, because if we figure out exactly why it happens, then we can put in measures to, I guess maybe stimulate the vagus nerve. That's why there's something called a vagus nerve stimulator. I'm not going to really talk too much about it because I'm not an expert in that area, and I don't, I take them out sometimes at Autopsy, but as far as like the extent of how they work and why they're put in, probably a neurologist is a better person to talk to. I'm the person who basically takes them out. If a person dies for sometimes they die with a seizure, sometimes they die for a different reason, and they have a vagus nerve stimulator. But that's it. I think that is a good, quick overview. Again, I don't want to make a very long podcast on this. It's something that is common enough that you need to know about it as a medical examiner. Somewhere between like 2 and 4% of all cases that come to a medical examiner's office are due to seizures, due to unexpected death with seizure. It is a common disorder, and the problem is, truthfully, is that when I do podcasts like this, it sometimes gives people concern. People who do have seizure disorders who worry, oh my gosh, is this going to happen to me? Well, they say that about out of 1,000 people with epilepsy, one might have SUDEP. Okay, so I guess a better way to put that is, if you have epilepsy, there's 999 chance out of 100 that you won't have SUDEP. So my recommendation is to keep your seizure medications in therapeutic range. Don't forget to take them. Don't stress the body too much. Sometimes I think they think that seizures can be related to, dehydration or electrolyte abnormalities, extreme stress. So you want to avoid those things. And that is probably, the extent of what needs to be done. Hopefully that maybe even new medications can be found that will be even better at blocking these epileptic seizures. But this is the baseline stuff of what we look for as pathologists. There's no magic wand. It's mostly a diagnosis of exclusion. It's mostly a diagnosis that we cannot make unless we have context. And that is a recurring theme, not only in my field, but in all of medicine and frankly, in all of life. You have to have context to understand what's happening. So with that, I'm going to go ahead and say that we're done today. It's about 30 minutes we went, and hopefully you learned something. If you have any questions or comments, please email me or hit me at one of my social media sites. There is a chance that I misspoke on something. I'm not perfect, and I like to correct when I do make errors, because I never script these things. I just talk off the top of my head, sitting alone. I'm recording in a different area today as well, so if it's echoey or it sounds strange, that's the reason why. But thanks again for listening, and I will try to get more podcasts up soon. Please visit my socials or mention if there's anything you want to learn about. All right. Thank you very much.